Good evening, friends. I'm Dr. Thiyagarajan. I'm an endocrinologist from Coimbatore, Tamil Nadu. Today, I will be discussing an interesting case I saw in the last few days. This is a 58-year-old gentleman. He has had type 2 diabetes for the last 4 years. He also has class 2 obesity, hypertension, hyperlipidemia, and obstructive sleep apnea. On his visit, he was noted to have a heart rate of 60 beats per minute, a blood pressure of 130 over 82 millimeters mercury, and his BMI has been stable over the past 1 year at 32 kilogram per meter squared, despite lifestyle changes that he has been making as best as he could. He came with a set of laboratory measurements that I asked him to do, and it showed a hemoglobin A1c of 8.3%, kidney function good at eGFR of 70 ml per minute per 1.73 meter squared. His lipid profile showed an LDL of 69 milligram per deciliter, HDL of 35, triglycerides of 250. His AST was 70 and ALT was 100 units per liter. Currently, his medications include metformin 1000 milligram twice daily. He's also on lisinopril 40 milligram daily, metoprolol extended release 100 milligram daily, atorvastatin 40 milligram daily, and aspirin daily. So who do we have here? So this is a gentleman who's relatively young. He has a short duration of only 4 years of diabetes. He does not have any previous major comorbidities or complications such as cardiovascular disease. He does not have any risk factors for having hyperglycemia. So this is somebody who would benefit from a more stringent HbA1c goal, I would say. He also has obesity, which should be factored in when we choose pharmacotherapy for him. He has hypertension, hyperlipidemia, and obstructive sleep apnea. And in fact, he is on continuous positive airway pressure therapy every night for the last 6 months. So what do various professional societies recommend? ADA says less than 7% HbA1c is a reasonable goal for most of our adult patients with diabetes. So when we are considering pharmacotherapy for type 2 diabetes in somebody like our gentleman here, in addition to efficacy, we should also consider what's the risk of hypoglycemia, whether we have to minimize weight gain and preferably promote weight loss, whether the patient in front of us has known atherosclerotic cardiovascular disease or risk factors of heart failure, chronic kidney disease, and also if there is any financial constraints and whether cost has to be factored in deciding the treatment. Our patient here understands that glycemic control is not optimal at this point and is willing to consider or willing to start another medication. But he has a problem. He often forgets to take his meds and he's afraid that if we start him on another 2 or 3 pills, this is going to get worse. He may miss several pills a day. He also has a fear of needles and he does not want to have any injectable therapy as of now. So in somebody like him, fixed dose combinations are a boon. They improve patient adherence because most of these fixed dose combination are once daily dosing, so makes it less complex regimen. Fewer pills, better adherence. Also, some of these combinations also improve the side effect profile or have less chances of side effects. And that's the benefit of fixed dose combinations. Usually the type 2 diabetes patients that we see in our office have other comorbidities. That may be hypertension, maybe cardiovascular disease. Monotherapy cannot address these multiple defects. So more often than not, monotherapy eventually leads to failure to maintain glycemic control over a period of time. Again, current guidelines encourage early adoption of combination therapies while simultaneously emphasizing individualized treatment. Say, for example, ADA in their most recent standards of care recommend that in high-risk individuals with type 2 diabetes, the decision to treat with either a GLP-1 receptor agonist or SGLT2 inhibitor to reduce major adverse cardiovascular events, hospitalization for heart failure, cardiovascular death, or chronic kidney disease progression should be considered independent of what his or her baseline HbA1c or what the individualized HbA1c target is for the patient. Empagliflozin linagliptin fixed dose combination is a first-in-class treatment of a combination of SGLT2 inhibitor and a DPP4 inhibitor. SGLT2 inhibitors are a new class of glucose-lowering agent that decreases the glucose by acting on the sodium glucose cotransporter 2 in the proximal tubule of the kidney and increases urinary glucose excretion. The salutary effect of this agent is its ability to act independent of insulin secretion, and so it is suitable to start this class of medications at any stage of the type 2 diabetes course, may it an early disease course such as our patient, or even at a late stage where the patient has already been on insulin. These agents still work. They also have other pleiotropic benefits and has been clearly established their benefits in multiple trials. The EMPA-REG outcome trial reported a significant reduction in 3-point MACE compared to placebo. Now coming to DPP4 inhibitors, they lower glucose by increasing the incretin hormones and subsequently augmenting the glucose-dependent insulin secretion and inhibition of glucagon release. So when you combine an SGLT2 inhibitor and a DPP4 inhibitor, it has the potential to have additive glycemic benefit because they act in complementary pathways, so the glycemic control is better than either one of them individually. And DPP4 inhibitors have also established their safety, especially with linagliptin. Two major trials, Carmelina and Carolina trial, have clearly shown the cardiovascular safety of linagliptin compared to placebo or the comparator drug. A fixed dose combination of these medications, EMPA and Lina, has shown an 1.81% HbA1c reduction at 24 weeks in people who are already treated with metformin. This is just the drug we want. Our patient who's already on metformin, who needs the HbA1c reduced, this combination will do the job. And the study has also shown that the benefits of glycemic control maintained at week 52. A higher percentage of subjects who were on this combination achieved the HbA1c goal of less than 7% without an increase in the risk of hypoglycemia or weight gain. And also they had a favorable overall lipid profile. It has also been shown that when a DPP4 inhibitor is added to the SGLT2 inhibitor, the incidence of genital infections are reduced, and this may be because of better glucose control, or there may be other possible mechanisms that are yet to come to light and need more investigations. In summary, the fixed drug combination of empagliflozin and linagliptin provides robust HbA1c reduction and higher odds of achieving the goal HbA1c compared to individual agents with low risk of hypoglycemia and a favorable side effect profile. I thank you all for patiently listening. I hope you will appreciate the benefit of this fixed drug combination. Thank you.